Hi, this is Jean Deschamps from Sonovault. This video will discuss the basics of deep vein thrombosis assessment. This video is part of a series of videos on vascular assessment. At the end of this video, you will be able to identify the different components at play in a basic DVT assessment, understand the differences with the full evaluation, understand anatomy and technique, and understand the limits of the compressive technique. We will start with the basic concepts for DVT compression ultrasound. The first part of understanding the DVT exam is identifying which tests you're performing and the limits associated. The vascular lab, as per the 2018 consensus report, should be performing a complete duplex ultrasound. This includes a full-length vascular compression exam coupled with color and spectral Doppler. The exam performed by POCUS users usually lack the color and spectral Doppler component and range from a 2-point to extended exam. It is critical to understand that while the 2 points and extended exams are good exams, they have limitations in terms of troubleshooting the type, chronicity, and exact location of thrombus in more complex cases. They also have limits in troubleshooting confounders that may mimic acute thrombus in some situations. POCUS users go from a 2-region compressive ultrasound all the way to an extended compressive ultrasound. The nomenclature is not entirely standardized, and you have to understand that there is a significant overlap between 3-region and extended exams. Both the 3-region exam and the extended exam will cover the femoral vein region. The difference is whether you should compress a single time in the 3-region exam versus compressing at regular intervals all the way down to the Popliteal in the extended exam. Given the multiple types of studies that can be performed, a meta-analysis tried to compare a 2-point and 3-point protocol. The meta-analysis of about 16 studies performed in varied settings showed that there was very likely little difference. Logically, there is likely a small benefit for finding some localized non-completely occlusive DVTs with both the 3-point and extended exams. Of course, this is at the expense of less specificity. Regardless, the Society of Radiologists recommends for POCUS users to use an extended compressive ultrasound exam. The extended exam is favored because it will detect isolated femoral vein thrombosis that is present in 5 to 7% of those with DVTs. They acknowledge the lack of formal comparison in head-to-head studies, but overall feel like there is less harm in finding more suspicious clots than having false positives. An important point based on this technical distinction is the aim of our POCUS studies for DVT assessment. We are trying to add to your clinical impression. This is not a diagnostic study in the traditional sense, but rather an aid to diagnosis. We are triaging for appropriate diagnosis to redirect patients who benefit from earlier formal diagnostic evaluation. We are attempting to expedite and direct disposition. And finally, we are trying to strengthen our decision to anticoagulate. This decision should, for the most part, remain based on other clinical assessment tools. Accordingly, the Society highlights this point in their consensus document. Specifically, a negative limited study in patients with a significant risk by other criteria warrants a repeat scan in 5 to 7 days. To strengthen this point, note that even a negative full vascular lab study may warrant a repeat study in the right clinical scenario. The key message here is that a negative POCUS study does not obviate the need for a formal ultrasound study if there is significant clinical suspicion. And in a lot of cases, because most of us see patients out of the emergency department, there was significant clinical suspicion because we took the probe out. I want to stress this point early on because I want our viewers to look at this study in context of this and not be blinded by the images. We will next go over the anatomy and technique. The anatomy for the venous system in lower and upper extremities is divided into deep and superficial veins, with those being linked by perforator veins. The deep veins lie beneath the muscular fascia, as seen in the CT venogram, seen on the screen. The superficial veins thus lie above it, and the perforator veins link both. Our ultrasound focuses on the deep veins, but we will look at segments of perforator veins as well. First thing to understand is that whichever type of study you decide to use, it is not 2 or 3 compression, but rather 2 or 3 regions. There are usually multiple compressions in each region. The main focus is the deep veins, but we also will look at the junction to one superficial vein, the greater saphenous vein, and one perforator vein, the lateral perforator. Why are we going to look at the junctions? Because of varicose-striate. Areas of junction tend to have competitive flow and areas of stagnation that make it more prone to forming clots. Clinically in the guidelines, a greater saphenous vein is included in assessment for DVT despite being a superficial vein because it will often progress into obstructing the common femoral vein. The technique will be performed using a cross-sectional view of the vessels. First look will be performed to look for any obvious abnormalities in the vessels themselves. The vessel will then be compressed using the probe. 2 main technical elements have to always be kept in mind. First, ensure you are compressing straight down, perpendicular to the vessel's long axis. This is essential to ensure that you are compressing where you're looking and not distal or proximal to where your ultrasound beam interacts with the vessel. Second, ensure that you are compressing until the artery is slightly squished. This is your scale to ensure that you are compressing with enough force to collapse the vein. This will look like this during a formal evaluation. Notice that the gain is optimized to ensure that there is an anechoic space in the vessel and not any overgained gray areas. The vessels are then compressed until the artery collapses partially. This exam can be performed with the leg in any position, but it is clearly easier with a patient well positioned. In this instance, a frog leg position allows to properly assess all the vessels. The advantage is that the probe can then be placed on a flat surface without any angle for the femoral vessels, making the exam easier. It also allows easier access to the popliteal vessels located behind the knees. Remember that we will go over 3 regions, but there will be multiple compressions per region. Here's a schematic representation of the different veins we will be surveying during the assessment. This is an accurate representation of the localization, direction, and attachments of the vein as compared to the arteries. We will be going over each level sequentially in parallel to the ultrasonographic images. The common femoral vein is the first in the assessment. It is found just below the inguinal ligament, as it becomes the external iliac vein proximal to it. You can start off at the inguinal ligament and locate the vessels to compress them. Sliding more distally, you will get to the saphenofemoral junction. This is the junction to the greater saphenous vein, one of the largest peripheral superficial veins in the body. Ensure that you can identify this junction in every assessment, as you want to ensure you compress at it as well as above it, as seen in the previous slide. Compression while keeping this in view can be difficult, but this is an area where clot is more likely to form. One note here is that the exact direction the greater saphenous vein takes is not always clear. Essentially, this is a vein that runs alongside the medial part of the thigh down to the calf. As such, it should originate from the interior portion of the vessel in the image. What changes is how your leg is positioned and how your probe is positioned relative to one another. If your probe comes right over the GSV, it will look like it's coming straight up, then diverge on the right or on the left on the screen. Whether it goes right or left, it is still meated on the thigh anatomically. This is very important to obtain because there is an overlap between deep vein thrombosis and superficial vein thrombosis in those junctional areas. In this case, a thrombus isolated in the greater saphenous vein, but within 3 centimeters of the junction, would be treated exactly as a deep vein thrombosis. This is because they tend to extend if left untreated. Past the saphenofemoral junction, you will come across the lateral perforator junction. This perforator vein will link up with the superficial vessels on the lateral side of the thigh. As the artery is positioned more lateral than the vein, the lateral perforator thus goes towards the artery on the screen. The essential part to remember is that it crosses between the superficial femoral artery and deep femoral artery, right below the junction. This term for lateral perforator is a description from POCUS users, as it has no formal name in any anatomical or radiological ultrasound textbooks I could find. It is unclear what to do regarding clots that are isolated to the segment, but I would strongly consider treating them similar to a greater saphenous vein clot. Advancing further up, we come across a junction between the femoral and deep femoral veins. Up to now, the main vessel has remained the common femoral vein with only vessels joining into it. This is where it dissociates into two other vessels of different names. Please note here that there are thin valves in each of the vessels. Don't mistake the bottom vessel for an artifactual image. Compress then at the junction itself. Finally, staying on the femoral vein, you should either compress once past the junction if doing a 3-point compressive ultrasound, or do a compression every 2 cm all the way down to the popliteal vessels, if doing an extended exam. The femoral vein can then be followed for a large portion of the thigh, but it may be lost approaching the knee as it dives down posteriorly. The deep femoral vein usually dives down quite rapidly and tapers off into smaller vessels by mid-thigh. It thus usually can't be followed much farther. There is possibly mild evidence that you may pick up some non-obstructive localized thrombi if you compress and scan all the way down to the popliteal. However, it is questionable whether or not it would actually change your management. Fully occlusive thrombus should have repercussions on more distal vessels if present, which would then give you a positive study. Non-occlusive thrombus are unlikely to significantly affect compression, but it may affect Doppler flows. A quick stop here to ensure nomenclature is well understood. All nomenclature referred to a superficial femoral vein, which is anatomically correct as it is more superficial than the deep vein. But it remains, however, a deep vein. As such, the current nomenclature refers to this as the femoral or sartorial vein, as it tends to approximate the path of the sartorial muscle. Finally, we approach the popliteal fold and the popliteal vein. At this level, there is a split between the anterior and posterior tibial veins. The peroneal vein then emerges from the posterior tibial, going in a direction between both tibial veins. Sometimes, there's an actual trifurcation, as a junction can be quite high up. For the purpose of our exam, we are most interested in the junction and the first few centimeters of each vessel. Generally, anything below the popliteal vein is considered a distal DVT and does not necessarily warrant anticoagulation. The reason we look at the first couple centimeters is because these can extend and should be treated as DVT. The veins in this region can be quite difficult to find. The frog-leg position is very helpful, but if you cannot obtain it, flexing the knee up in the bed, forming a triangle between the thigh, calf, and bed, allows you to place the probe appropriately. Let's look over a few normal and pathological findings as you can understand what to look for. The traditional teaching is that fresh clot is black. This is in part true. Newer machines allow a much more detailed assessment of white, gray, black differentiation. It is often the case that you will be able to see something within the vessel as clot organizes. This assumes that you are compressing where the clot is. In some instances, you may not find clot exactly where you are looking, but the vessel won't compress down. This is because there is clot higher up, and the distal segments of the vessel cannot be compressed easily due to high resistance to flow. The clip on the left of the screen shows a non-compressible common femoral vein. It is the left vessel in this clip. Additionally, you suspect that there is likely some material within the vessel, even though there is a bit of overgaining. The clip on the right of the screen shows a partially collapsible vein. In part of the clip, when looking at the lateral perforator, you may notice that a common femoral vein appears to have some kind of material within the lumen. These two clips show valves that are very commonly found in both femoral but also jugular veins. The clip on the left shows multiple femoral vein valves. The one on the right shows a single valve in the deep internal jugular going into the subclavian. These two clips are from the same patient, one in a cross-sectional view and one in a longitudinal view. You can see here a partial thrombus of denser material that is organized and attached to the interior wall. Finally, these are more organized and older clots that are quite easily appreciated. The clip on the left is from a large, completely occlusive internal jugular clot. The one on the right is a completely occlusive, older, organized, common femoral vein thrombus. As you can see, thrombus, even acute, can be appreciated under ultrasound. There are some density, shape, and compressibility criteria that are used to determine chronicity, but this is beyond what we are looking for on a practical sense at this level. The DVT assessment is fraught with confounders, and we will discuss a few important ones here. If you want a more detailed overview of all the pitfalls, have a look at this article that goes over them quite well. In short, any round structure can look like a vessel with material in it and create a false positive. Most commonly, lymph nodes and nerves are frequent offenders. Make sure you are identifying the partnered arterial vessels, and this mistake can be quite easily avoided. Occasionally, you will have a duplicate venous system, and one limb can be thrombosed while the other isn't. If you're not aware this exists, this can make an exam appear falsely negative. Overall, this exam tends to have pretty good specificity in the more 95% range, with reasonable low intermediate sensitivity in the 50 to 60% range. This means a positive test is useful and likely rules in an actual DVT most of the time. However, in the emergency department, a negative test may miss a fair amount of DVTs using a single 2-point compression. One of the most common pitfalls is technical. It is critical to be compressing while leaving the probe perfectly perpendicular to the vessel. If this is not done this way, the compression appears to have no effect, as the pressure is not exerted while the ultrasound beam is looking. Finally, let's go over the logic of using this diagnostic test. As discussed previously, we are not performing a diagnostic study at this point. With increased competence, time, and additional tools such as the power Doppler, this may be considered a diagnostic study in some hands. Regardless, you have to be mindful of using this in context of a DVT clinical risk assessment tool. Remember too that the extended exam and the 2-point exam are good at rule in, but less good at ruling out. What we have here on the screen is an emergency department clinical assessment algorithm. Keep in mind, these are patients that were not in hospital and came in with symptoms suggestive of this pathology. In this algorithm, if the patient is high risk and has either a positive complete duplex ultrasound or an extended study, they should be treated because it is likely a DVT. However, if the extended study is performed in negative, it should be repeated in 5 to 7 days because of the more limited sensitivity. An alternative is to get a complete duplex ultrasound to tip the scales. As discussed previously, however, even a complete negative study may warrant being repeated if the patient is high risk, especially if there are persistent symptoms. As such, in the meantime, deciding to integrate the patient with a negative test should be based on the risk-benefit ratio for this patient, regardless of the extended versus complete study. Remember, this is a useful test if positive to strengthen your decision to anticoagulate in comparison to the risk of not doing so. Why is it that a negative study may lead to a later positive study? There are a number of reasons, but one important one is that the cath is not done in the extended exam and only done in a limited fashion with the complete exam. Even in the complete duplex ultrasound, if performed, sensitivity remains low in these small, hard-to-find vessels. A second scan can be positive in up to 12.8% of patients, sometimes due to an initial missed thrombus that progressed. Overall, though, it is less common than the large proximal DVT is missed. It is also noteworthy that most of the literature is for ED patients, which are not the same as inpatients. Indeed, in one study for inpatient critical care, the sensitivity was quite notably higher. This may be because these patients have a higher number of confounders, but also have a higher baseline risk for DVT formation. In summary, think about your pretest probability. If it's high, you may and probably should anticoagulate even if you have a negative extended study. This is not where the test is most useful. It becomes more useful if there is low or moderate risk, where it could actually change your management because you have a more likely outer cause. And a positive finding would really push you towards anticoagulation. This is the end of this video on basic compression ultrasound for DVTs. Please reach out on Twitter or through the YouTube channel for any questions.